So it's a great honor to introduce Dr. Reisa Sperling, Professor of Neurology at Harvard Medical School, Raimondi Family Distinguished Chair in Neurology at Brigham and Women's Hospital, and Director of the Center for Alzheimer's Research and Treatment at MGH. Just this past year, Reisa earned the title of one of the country's most disruptive women to watch in healthcare because of her seminal work challenging the field of Alzheimer's research, showing that neuropathology can emerge long before clinical symptoms of dementia become apparent. Because of Reisa's work primarily using PET imaging, we now know that about a third of cognitively normal older adults actually have significant amyloid burden. She's linked the neuropathological trajectories of Alzheimer's disease to complex and dynamic changes in activity and connectivity of key nodes of the default mode network, including the hippocampus. Reisa's argued that combating Alzheimer's disease requires that we understand and target this early preclinical stage of the disease before the disease takes over, and in a sense, it becomes too late. Towards that end, she's been coordinating a large international Alzheimer prevention study in over 1,000 older adults with preclinical AD to test the efficacy of drugs that clear amyloid from the brain. In addition to the far-reaching impact of her research on shaping the field of clinical neuroscience, Reisa has touched the lives of numerous patients and trainees. Her excellence in clinical practice and mentorship has earned her several awards, including Boston's Best Doctor Award for multiple years. She's also touched my own life in ways that she's probably not aware of. Ever since I was a student at MGH, I've always looked up to Reisa and considered her an important role model of mine, despite that she was never my official mentor. Her work linking Alzheimer's disease to the default mode network is one of the reasons why this network is so near and dear to my own heart. As you'll soon glean from her talk, Reisa shows a fearless dedication and contagious passion for her research, as well as a sincere goal to improve the lives of so many people suffering from dementia. I'm sure that many of you in the audience also find her as inspiring as I do, so please join me in welcoming Dr. Reisa Sperling.
That was very nice, thank you. Well, thank you so much. Can you guys hear me all right? Terrific. Well, it's a real honor to be invited to give this talk, and thank you so much, Jess. I would be thrilled if I inspired one teeny bit of your work. All right, let me first show you my disclosures and also highlight the people who funded some of the work I'm going to be showing you. But most importantly, my first disclosure and most important disclosure is that I am a cognitive neuroscience wannabe. I'm a clinical neurologist, as Jess told you, and I have to admit to being a little intimidated to speak to this audience because it's been thrilling over the past day and a half to be able to see the really incredible cognitive neuroscience work. So I'm going to show you how I have viewed memory through the lens of Alzheimer's disease, which, as I'm sure many of you know, is a progressive neurodegenerative disorder. It's an incredible window into progressive memory loss and the network destruction of the brain due to pathology that accumulates. But it's messy, as we were discussing at lunch. And I suspect that some of the experiments I show you, you will think are rather simple and not nearly as elegant and sophisticated as the tremendous work others have shown over the past couple of days. But it is really to the heart of why memory is so important. Memory is who makes us who we are, and unfortunately, that's what's lost in Alzheimer's disease. And so I'm thrilled to see our fields coming together, cognitive neuroscience, aging work, and Alzheimer's disease, very, very early Alzheimer's disease, to try to figure this out. All right, so for those of you who wish to take a postprandial nap, these are the few points I'm going to be making, so I'll go through them and then feel free to snore, although I can see over this podium a little bit, so I'll know when you're snoring. So the main points are, as Jess was saying, so Alzheimer's disease pathology is very common in normal older individuals. And one of the things I like to really discuss in people who are studying cognitive aging is to be aware of this, because it may actually contaminate some of your participants more than you might think, and might contribute at least somewhat to cognitive changes that are attributed to normal aging. And you'll notice I put normal in quotes many times, because the older I get, there is no normal thing about brain getting older. The topology, the anatomy of Alzheimer's pathology is fascinating because of its overlap with the memory networks that you've been seeing over the past couple of days. And I'll really highlight this because for me, this is the coming together of these two interests of cognitive neuroscience networks and Alzheimer's disease. So Alzheimer's biomarkers, as I'll show you, are associated with very early functional changes in these memory networks, although not all of these changes are decreases in activation, and I will take you through the bane of my existence, the up before the down hyperactivity that I think we still don't fully understand. And importantly, these Alzheimer's biomarkers do predict future cognitive decline in clinically normal older individuals. And from my point of view, this is an opportunity to try to treat people before they get to the devastating stage of Alzheimer's disease and have irreversible neuronal loss. So I'll end my talk by really focusing on some of the prevention trials that Jess mentioned that we are looking at to try to prevent the cognitive decline. All right, so since Earth Day is coming up, I'm going to punctuate my talk with a bunch of Mother Nature analogies, and this is the first one, the proverbial tip of the iceberg. So most people recognize Alzheimer's disease at this stage where the symptoms are already fulminant, where people have dementia or cognitive impairment. But I'm going to argue throughout this talk that really Alzheimer's disease is what's lurking beneath the surface. And the number of people who have Alzheimer's disease changes that are beginning in their brains well before they get to the stage that we recognize as clinical dementia of Alzheimer's disease. And those of you in the audience who are working on things like heart disease and cancer and other diseases that are associated with aging, you're doing a very good job of keeping people alive longer and unfortunately creating an epidemic of Alzheimer's disease. And from a public health point of view, it is really this hitting this part of the iceberg that we can't see. The millions of individuals, it's estimated that about 10,000 baby boomers every day turn age 65 for the next, I think it's 7 more years, entering the age of risk for Alzheimer's disease. So we really need to take this seriously as a society as well. Now, if you took that iceberg and you turned it on its side, it would look something like this. This is a classic Alzheimer's disease diagram. So we recognize Alzheimer's disease, as I said, at the stage of dementia. About 20 years ago, it was recognized there's an earlier stage, often referred to as mild cognitive impairment, or MCI. In the setting of having positive Alzheimer's disease biomarkers, we now refer to this stage as prodromal. These are people who already have symptoms, but they're still functioning normally, this stage of MCI. And what I'm really going to focus on is trying to move back up this trajectory even further. Let's see if you can see this. To the stage where cognition is still clinically normal, or it's indistinguishable on most tests from those individuals who are normal aging. So this is what I'll argue is an asymptomatic or a preclinical stage of Alzheimer's disease. And I think this is when we ought to be detecting Alzheimer's disease and treating it. So just in case most of you don't look at brains under the microscope all day long, I want to remind you of what the neuropathology of Alzheimer's disease looks like. And importantly, to show you what we can see with imaging techniques and what we cannot. So of course, these are the extracellular collections. These are Alzheimer's disease neuritic plaques. They're collections of proteins, mostly A-beta peptide 1 to 42. And they, as I said, are extracellular. And there's a big debate in our field still whether it's the plaques that are the problem or whether it's the soluble or oligomeric forms of A-beta that are often the toxic halos around these plaques. The other pathology of Alzheimer's disease are tangles, neurofibrillary tangles. These are hyperphosphorylated collections of tau, and these are intraneuronal and are much more closely linked to cell death and cognitive change. So I'm going to give a shorthand here for talking about A-beta or amyloid and tau, but these are really the pathologies that we can see under the microscope and also what we can see with PET imaging. We can only see them in their aggregated forms. So we can only see amyloid when it's in a beta-pleated sheet structure with PET, and we can only see tau generally when it's in a paired helical filament form. So there's lots of floating around amyloid and tau that we can't image, and with spinal fluid we can only look at the single monomer peptide, so there's still kind of a black box between what are the real toxic species of these pathologies. But nevertheless, I'm going to show you what we can see and how that's related to changes in aging and memory. All right, so we and many other people started these PET studies now about 10 or 11 years ago already. And the first thing that we saw is that people with Alzheimer's disease dementia, not surprisingly, about 80% of them have very elevated amyloid plaque already. And so this is an example. This is a patient who I think has an MMSE of 22, so pretty mild dementia, and their brain is already, I like to say, plasticized with amyloid. So, and again, it's in all of the heteromodal cortices and already at very high levels. This stage of MCI, mild cognitive impairment, it's about 60-40, and the 60% of MCI patients who have elevated amyloid have a 5.5 times likelihood of progression to Alzheimer's disease dementia over the course of the next 3 to 5 years compared to MCIs who don't have amyloid. But I'm really going to focus on these CNs, we call them clinically normal older individuals, who are in the Harvard Aging Brain Study that we've been following longitudinally now, some of them for about 7 to 8 years. So these individuals who are clinically normal, they come into the study, they are really normal. In fact, you would probably call them supernormals in some ways because they perform very well on all these tests. We do allow people who have other normal health issues like hypertension or diabetes, but we do screen them quite carefully for their cognition. About a third, or 32% to be exact if you're over age 65, have evidence of elevated amyloid. Moreover, they have elevated amyloid in exactly the same anatomic pattern that you see at the stage of Alzheimer's disease dementia, just not up quite at the same level yet. So that raises the question as to whether these people are in the preclinical stages of Alzheimer's disease. So I'm going to illustrate this with a graph from my colleagues down under from the ABLE study. This is the prevalence of Alzheimer's disease dementia clinically. As I mentioned, it's very age-linked. It doubles every decade, the number of people who have clinical Alzheimer's disease dementia. Shown here in green is the likelihood that if you're a normal person and you were just participating in one of your cognitive neuroscience experiments, but you were hit by a bus on the way out of the door, even though you were perfectly normal, that if they did an autopsy, they would see evidence that that person has sufficient Alzheimer's pathology to meet a neuropathologic diagnosis of Alzheimer's disease dementia. I'll argue that this curve has exactly the same shape, it's just translated over. And here in blue dots are the likelihood at those ages, these are fewer age sampling, that you are PET positive or amyloid positive on a PET scan. And the PET data, as well as the spinal fluid data, maps nearly perfectly onto this autopsy data. So we don't yet know whether all the blue diamonds are going to progress to become blue circles are going to progress to become red diamonds and develop dementia. But if we see amyloid on a PET scan, the likelihood that there's amyloid at autopsy exceeds 99.2% in now over 500 autopsy cases. So very good marker for showing there's amyloid, fibrillar amyloid in the brain. So as I said, we don't yet know what will happen to these people longitudinally. This original estimate suggests that it's about 15 years between the time that you have sufficient amyloid plaque buildup to meet a neuropathologic diagnosis of Alzheimer's disease and you get to the stage of clinical dementia. Well, for me, that's a glass half full. 15 years potentially to be able to stop those blue circles from progressing. Now, a lot of the work I'm going to show you has really been trying to fill in those 15 years and say, can we actually see what happens to people over time? Because, of course, these are three cross-sectional studies laid out. So here's some data that was published from ADNI, the Alzheimer's Disease Neuroimaging Initiative. Some of you may have heard about this multi-center study. It was started about 11 or 12 years ago now. And initially, they had normals in the study only because they wanted controls for their MCIs and AD dementia patients. But it turned out that about 34% of the ADNI normals also had elevated amyloid, some on spinal fluid, some on PET imaging, first with PIB and later with florbetapir. And we were able to follow those people over time and see what happened. So showing you in blue are the amyloid negative, or no evidence of amyloid over time. You do see that there is a decline over time, but it's much attenuated. And the first thing you see is actually a little bit of a practice effect on the tests over time if you don't have amyloid. Shown here in orange are individuals who had elevated amyloid at baseline even though they were normal. And this is what happens to their cognitive composite over the course of 10 years. It's estimated that 88% of the normals in ADNI progressed to symptomatic Alzheimer's disease within those 10 years. So pretty significant risk factor. But clearly, there are some people who progress faster and some slower. And I'll come back to that point. So we've been trying to deconstruct this composite, trying to understand what is really changing over time. This is tremendous work by Beth Mormino, my colleague, was my postdoc, is now a colleague of Anthony Wagner's and others at Stanford, who's been fantastic. So this is data now from the Harvard Aging Brain Study. Very similar curves, except that some of the tests we do the same each year and some have alternate versions. And what you can see, again, the blue are the amyloid negatives. They get better over time, particularly on the test. They get the same version every year. And in red are the amyloid positives. All of these individuals started out, again, in the Harvard Aging Brain Study as pretty super normals in terms of cognition. But on every one of these tests, both on memory and, somewhat surprising to me, executive function as well, the amyloid positive individuals either had less of a practice effect, as you can see here, or frank decline on these tests over the course of 5 years. So one of the things we've really been trying to understand is what accounts for the variability in why some people decline very quickly and other people decline more slowly or more resilient. And this is kind of a model that I'm going to come back to as I show you some other imaging markers here that we've been working on. So everybody over the age of 40, I'm sorry to tell you this, actually there's a lot of people under 40 here, it's okay, are accumulating tau in your medial temporal lobe, particularly in the transentorhinal cortex. And by the time you're age 80, 92% of you have significant tangles in your entorhinal cortex. And again, this really accelerates between age 40 and age 60, which those of us in that age range can attest to. One idea is that, so age is associated with tau, age and genetics are very strongly associated with amyloid accumulation. And one thing that we're really trying to test is whether one of the ways amyloid begets cognitive decline is that it accelerates tau spreading from the medial temporal lobe into the neocortex. And I'll show you a little bit of that data. So about 4, maybe 5 years ago now, we could finally image the other hallmark pathology of Alzheimer's disease, and those tangles I showed you in the intraneuronal neurofibrillary tangles. By the stage of Alzheimer's dementia, you not only have a head full of amyloid, unfortunately, you already have a head full of tau. This is a person with very mild dementia, an MMSE of 24 at the time that these images were taken. The good news is that the 2/3 of older people who don't have amyloid generally have tau restricted just to the medial temporal lobe. Sometimes it's beyond the transentorhinal cortex, but it's really restricted primarily in the medial temporal lobe. But this group of clinically normal individuals who are amyloid positive, already have a lot of amyloid, we see evidence that the tau is now spreading into the hippocampus in the medial temporal lobe and outside of the hippocampus into the surrounding inferior temporal neocortex and other regions that I'll show you. Again, suggestive that this is the beginning of Alzheimer's disease. So this person was absolutely normal. I think she had an MMSE of 28 at the time of this images were taken, and unfortunately within 2 years she progressed to MCI, and I saw her last year, and she now has an MMSE of 19 over the course of about 4 years. So I think this is the pattern of, unfortunately, impending memory impairment. So as I mentioned to you, I'm really interested in this idea of the topology or the anatomy of how Alzheimer's disease pathology really targets the core or memory network. It's the default network, but it's beyond the default network because it differentially targets specific parts of this. So you saw this beautiful picture that Dan showed yesterday from his work back in 2007, and I've always been very struck by the components that they pulled out in this diagram, and in particular the medial parietal cortices, the precuneus and the posterior cingulate, as well as medial, prefrontal, lateral parietal, and then very interestingly, the other parts, of course, that you know well working on memory, the medial temporal lobe as well. So one of the most interesting things to me as we started to do the functional MRI work, this is where my roots come from, is how that anatomy actually overlaps where Alzheimer's disease pathology will occur. So these regions up in the heteromodal parietal cortices and in the prefrontal medial cortices are the first places you see amyloid up here in clinically normal people. And that's actually shown in this diagram. Tau, on the other hand, starts, as I said, in the entorhinal cortex and spreads into the rest of the medial temporal lobe and then out into the lateral and inferior temporal lobe. So as the disease progresses, the amyloid in the cortex spreads down to the tau in the medial temporal lobe, and the tau in the medial temporal lobe spreads out into the cortex. But even until pretty late in Alzheimer's disease, it's restricted largely to this network. You rarely see pathology in the primary sensory and motor cortices. And again, even at the stages of, I'll say, mild dementia, if you look at an Alzheimer's map, which I'll show you, of amyloid and tau, it looks a lot like a memory network. So perhaps it's not so surprising that memory is particularly vulnerable in Alzheimer's disease. So to talk about this, I have to take a little bit of a detour back in my field to when I worked on functional MRI. I still try to do this as much as I can, and I really got inspired here to go back and start some new experiments, so thank you very much. I studied how people remember names and faces because it's the most common complaint of older individuals, and from Dr. Cohen's amazing talk, it's to me one of the highlights of relational or associative memory, because you can't make the association between a face and a first name unless your hippocampus does it, because there's nothing about this person who looks like a George unless you happen to know another George who looks like that. So I'd been working on this for a while, but we did this experiment way back 10 years ago now, where we were doing a classic subsequent memory experiment looking at what happens, what's changing in the brain at the time you view a face-name pair that you'll remember successfully subsequently 30 minutes later. And we compared young and older participants, and we further divided them into high and low performing, kind of a classic cognitive neuroscience experiment at the time. But we, just like many others had already shown, was that more activity in the hippocampus was associated with greater likelihood that you're going to remember this later or not. But at that time, one of the things that hadn't been well reported is that the degree to which you deactivate the posterior cingulate or the precuneus was equally, and in fact sometimes more predictive as to whether you'd remember that face name pair or not. Moreover, when we looked at the low-performing older adults in particular, we saw this somewhat strange phenomena that the main thing, the difference that they showed in their patterns of activation were that they failed to deactivate the posterior cingulate when they were encoding new face name pairs. And to get it right, because we were looking in this case at only stimuli they got correctly, they actually showed this hyperactivity or increase in their hippocampal activation at that point. So this was a little bit confusing, but by 2008, we were already starting that amyloid imaging, and this pattern looked very much like a PET scan in terms of an early amyloid scan. So the next study we did with a different group of older adults was to look at whether the areas that are deactivating to predict successful subsequent memory overlapped where people were accumulating amyloid in this region. And we looked first at a set of Alzheimer's disease dementia patients, people who were clearly impaired, and they showed this odd phenomena of not only not deactivating when they saw a novel face name pair, they actually activated or overactivated. This had already actually been reported by Cindy Lustig back in 2003 using a somewhat different paradigm, but we replicated that in Alzheimer's patients. Moreover, in the clinically normal older individuals who had elevated amyloid, we saw exactly that same phenomena, where they were aberrantly activating regions that should be turning off to remember. We did, as many other people have now seen, that in normal older people who don't have amyloid, there is a loss of modulation of the default network during encoding, but we didn't see this aberrant increase in activation that was associated with Alzheimer's disease. Now, we'd seen this hyperactivity before in the hippocampus, primarily at the stage of mild cognitive impairment. And this is some early work. It was shown yesterday in Professor Gluck's session. But we'd seen this evidence that in the hippocampus, there was increased activity, particularly in people who had early MCI, who were still performing reasonably well, but unfortunately very likely to decline over time. And individuals at the later stages of MCI, where they're fully amnestic, lost their hippocampal activity. So there seemed to be this up before the down during this phase of MCI. Now, these are all older people who, again, are already impaired, already have significant atrophy at that point. So the next experiment that I think really brought this home for me is now work in autosomal dominant disease. This is from the Colombian kindred. This is work by Yaquel Quiroz, who is a fantastic colleague of mine in Boston. So she took our face name test, translated it into Spanish, took it down to a 1.5T scanner in Medellin, Colombia, and did the same face name task. These people are between 18 and 36. This presenilin mutation causes Alzheimer's disease in 100% of the individuals who carry the mutation. They typically become symptomatic at age 39, and 100% of them have dementia by age 44. These individuals in this family, there are, I think, about 35 people in this study. They're compared between carriers and non-carriers. They don't know who carries the mutation within the same family. And what she found was that the asymptomatic carriers, again, between age 18 and 36, so all pre-symptomatic, showed evidence of failure of deactivation in the medial parietal regions, and interestingly, the same evidence of hyperactivity in the hippocampus in these individuals, even though these, the carriers versus the non-carriers performed identically on the fMRI task. So these are only changes in activation. Now, one of the other things, of course, over these 10 years was we realized it's really fun doing all this task fMRI, but you can see some of these same changes in resting state fMRI. This is data by Jazz Chatwal in our group looking at the Diane kindred. So now we're looking at multiple different autosomal dominant mutations, and we have the opportunity here to be able to look at people who are asymptomatic through early symptoms to dementia and compare them to their estimated symptom onset within their families. And what we can see is that even about 10 to 12 years before the age of average symptom onset in these families, you can see a disconnection between the posterior cingulate and the medial temporal lobe. And that this occurs, again, progressively as people get more symptoms and approach and go beyond the age of onset in their families. But even in this data early on, we could see that there was this evidence of hyperconnectivity, although it was very subtle, even before about 15 to 20 years before people developed their symptoms. So we started doing a resting state fMRI in older clinically normal individuals with and without amyloid. This is some of the early work with Trey Hedden. And this first piece, we thought, oh, this is golden. We can see that more amyloid goes with decreased functional connectivity. And again, it's pretty specific that it's decreased functional connectivity in the PIB positives between the posterior cingulate and the medial temporal lobe, highlighted here that these are the areas that are disconnected. But of course, the next 50 patients, participants we saw, we didn't see evidence of this at all. And as you heard in, again, the session yesterday, this has been a great debate as to whether there's disconnection in people who have elevated amyloid in their default mode connectivity or not. And again, sadly, I think we've been chasing this down for about 10 years, but I think we finally have some answers here. This is work by Aaron Schultz that was published in J Neuroscience last year. And what we did now, we have a larger number of people with amyloid imaging, and we splayed them along their degree of amyloidosis. And we saw evidence that the first thing is that we see a little bit of this hyperconnectivity as people develop more amyloid, and as they get even more amyloid, that starts to come down in this more inverse U-shaped curve or nonlinear trajectory. And I was really struck yesterday seeing this data by coming out from Karen Rodriguez and Kristen Kennedy, where they were actually showing a very similar pattern in their data using task data. So part of the reason I have to say that I stopped working in fMRI for a while was this nonlinearity, because as a biomarker for Alzheimer's disease, it's really tough if you don't know if more activation is a good thing or a bad thing. And you don't know which side of this curve you're on, and I thought, oh, it'll be great, resting state fMRI, it'll be nice and linear, but no. Unfortunately, it's even more complicated than that. So this is some work that came out last month in Brain, looking across autosomal dominant participants and older participants in the Harvard Aging Brain Study. I won't fully unpack this for you, but except the main point of this is that as Alzheimer's disease develops, you see first increases in connectivity, not only within network, but often you see this loss or this promiscuity of cross-network talk. That is one of the first things that changes in both autosomal dominant disease and in older normal people with amyloid. What did I do with my water? And unfortunately, I think it's going to be hard with a single network to be able to say where you are. But again, this abnormal or promiscuous crosstalk between networks that you can see here is a very specific sign of early Alzheimer's pathology. So I won't spend too much time on this hyperactivation because sadly I thought maybe we had figured it out over the past 10 years, and clearly we still haven't, so we've got some work to do. But there are a lot of potential underlying neurobiology. So we know that there are changes in acetylcholine in particular going up, there's desynchronization, and there's potentially this idea of compensatory neural recruitment. So in 2007, I thought, oh, that's what this is. This high activity is our people, their brains are working harder to form memories, and that's why we see more activity. That was a terrible idea, clearly not correct. More recently, there's been a lot of work, including Mike Yassa and Arnold Baker, I don't know if I'm pronouncing that properly, saying perhaps this is aberrant epileptiform activity, and I think some really nice data suggesting that when you quell this with levetiracetam or other anti-epileptics, you actually can quell the hyperactivity and potentially make memory better. And I think that really what we're seeing is that this is evidence of excitotoxicity and a harbinger of failure. So it may be compensatory to keep your hippocampus working at that moment, but it's a sign that it's going down. And I'll show you a little bit of that data. So this is actually some work from a while ago where we had people who were normal and early MCI. We followed them over time and again saw that this group who was rapid decliners started out with very elevated hippocampal activity. And at the time in 2008 when this study started, or 2007, we didn't have amyloid imaging yet. We didn't really know who these people were. We could just tell that their initial fMRI activity was a good predictor of who would decline over time. And hopefully this is going to show up, yeah. So then later in 2014 and 15, we recruited another group of individuals, MCI, very early MCI, and we looked at them on the basis of whether they had amyloid or not. And we could see that in fact it was these amyloid positive MCIs who had this hyperactivity. Moreover, that those amyloid-positive MCIs had smaller hippocampal volume, even though they had more activity. So it's not a matter of having more neurons, it's your few neurons that are left are gasping for function and are over-activating. And unfortunately, again, that's the group that progresses towards AD dementia within that 2 to 3 year period. So coming back to this idea that part of what's happening here is really that amyloid is associated with this neocortical tau accumulation and synaptic dysfunction going towards cognitive decline, I'll come to my second Mother Nature analogy, which is that it's like a forest fire. So we don't really yet know how amyloid and tau interact, but I think there's some evidence that amyloid may act as an accelerant, or that the same thing that's causing amyloid accumulation is also causing tau accumulation. So I want to show you a little bit of the evidence to support that. So this is data from the A4 study. I'll tell you more about this clinical trial in a moment. But we now actually have about 400 tau PET scans, but this is the first 239 that we were able to analyze. All of these people are clinically normal, and they're all in this study because they're amyloid positive. So they're that group of amyloid positives. But this is a map of tau PET, a group map of tau PET, and this is showing you where in the brain, if you're normal and you're amyloid positive, more amyloid is associated with more tau. So even within this restricted range, you can see that, again, the people who are very high in amyloid actually have very high tau levels, even though they're all still asymptomatic. And what's really concerning for me is that this also is related to their memory performance. So everyone who came into this trial had to be absolutely normal, normal MMSE, normal logical memory score. They had a lot of other testing, but still the amount of tau they have, particularly in their medial temporal lobe and out into these early inferior temporal regions and lateral temporal regions, is related to how they perform on the free and cued selective reminding, even though they all have to be within the normal range. So this benign tauopathy of aging, or this benign amyloid, even in this restricted range, is associated with worse performance. We now have some prospective data. This is back to the Harvard Aging Brain Study, where we had amyloid and tau on these individuals, and we're able to look at what happened to their memory prospectively over the next 2 years. One of the things we found that in individuals who don't have elevated amyloid, tau does not appear to be associated with memory function. Other groups have seen some evidence of this, but no matter how we look at it, in the absence of a lot of amyloid, you can have tau, but it doesn't seem to be associated with memory change, at least prospectively. Retrospectively may be different. And what we can see is that in the entorhinal cortex, hippocampal tau, or inferior temporal tau, it is that group in the red who's amyloid positive, who has very high levels of tau, even though these people are all normal at the time of tau imaging. That's the group, unfortunately, who's showing this very rapid decline. So my next Mother Nature analogy is the tsunami. And Alzheimer's disease is often likened to a tsunami. But I've come to realize that's not a very good analogy for Alzheimer's disease, because a tsunami is a once-in-a-lifetime wave. And Alzheimer's disease is wave after wave after wave. So we've got to be pretty aggressive and give these little guys here in the lifeboat a fighting chance. And that's why I'm going to spend the next part of my talk really focused on how we can actually do something about these people. Whenever I give this talk, people always ask me, why would you possibly want to tell someone that they're going to develop Alzheimer's disease symptoms in 10 years? And I always, because there's nothing you can do about it. Why would you want to tell anybody? And I always say, because that's the way we're going to be able to do something about it, just like every other disease that we've made progress. Cancer, HIV, osteoporosis, diabetes. As I'll say, this is really the way we've made progress in medicine is by detecting disease before people come in with symptoms. That's the point here. So the other case for earlier intervention is, of course, you can't open your newspaper without seeing, or your iPad or your phone, without seeing another clinical trial failure in Alzheimer's disease. We're batting less than 0, I think, with 12 phase 3 trial failures, particularly at the stage of mild to moderate dementia. We've been trying all of these drugs at the stage where there's already widespread neurodegeneration, not just amyloid and tau, but they're dead neurons. And I think, unfortunately, we could suck all the amyloid out of the brain at that stage, and I think it's unlikely we're going to fully arrest the clinical development. There have been some very mild signals in the very mildest group that we may be making a dent, and I'll show you a little bit of that. The other reason, of course, is a public health reason. If we don't have to cure Alzheimer's disease, we just have to delay dementia by 5 years, and it's thought that we can decrease Medicare costs by about 47%. And that's because, I like to say, people can die out ballroom dancing instead of in nursing homes. And of course, that's what I want. And as I already made this point, again, this is revolutionary perhaps and heretical in Alzheimer's disease, but it's exactly what we've done in every other disease. So this leads to the idea of these prevention trials. Most of the trials where we've seen this signal I'll call tertiary prevention. You've probably heard about the Biogen, the aducanumab. One of the things these trials have done right is they've already moved from dementia to MCI, and they've defined their population on the basis of having amyloid pathology. And we've already seen some signals that even this move might be helpful, but in pretty small trials. We all want primary prevention. We want something safe enough to put in the drinking water of everybody over the age of 18. Those 50-year trial designs, very hard to get funded by NIA still. And of course, we don't have a drug that's safe enough to really be using in primary prevention overall, although I think we're getting there. So really, the trials we're running right now are secondary prevention. And what I mean here are people who have the disease in their brain, but they don't yet show the clinical symptoms. And again, we do these secondary prevention trials in many other diseases, and we can now do them in Alzheimer's disease. Most of these secondary prevention trials are focused on these rare genetic forms of Alzheimer's disease, the autosomal dominant, also some ApoE4 homozygotes coming out of the Banner group led by Eric Ryman and Pierre Theriault. But I'll argue that dominantly inherited Alzheimer's disease and ApoE44 homozygotes together account for about 6% of Alzheimer's disease worldwide. So I sound like Bernie Sanders here, but it's time to do something about the other 94%. And we're trying to do that by using biomarkers to identify people in these earlier stages of disease. And that leads to the idea of the A4 study. I'll tell you just very briefly about these studies. So A4 is a secondary prevention trial in clinically normal people aged 65 to 85 who have to have evidence of amyloid PET on screening scans as they come in. It is a phase 3 randomized trial. The FDA changed their guidelines for the first time in 37 years to make these kinds of prevention trials like A4 go forward, and it's been thrilling to be able to start these trials. It's a very large trial and a very long trial. We're also following a group of individuals who screen fail, who are amyloid negative, who come in the LEARN trial. This is really important because, of course, everything that causes decline is not amyloid and tau. Even I recognize that. So it's important to follow this control group. And we also have an ethics sub-study. For the first time, we're really trying to understand and very carefully learn how we can disclose amyloid status to normal people, tell them what we know, and importantly, what we don't yet know. And hopefully, if these trials work, this will help us so that we'd be able to do this responsibly in larger populations. So these are the kind of biomarker curves you may have seen from the Alzheimer's world. This first red curve is the amyloid. Whoops, I told you I would do it. Okay, let me go back one more. This is the amyloid curve going up, and the A4 study is in people who are already clearly amyloid positive but are still in the normal range. And the idea here is that we want to move this amyloid positive curve back up towards that amyloid negative curve. And we're powered to see a 30% slowing in that rate of decline. That may not seem like a lot, but slowing that decline in the preclinical phase by 30% will prevent, in this age group, 52% of dementia cases. Because again, they'll be out ballroom dancing until hopefully they succumb to something else. So I always get asked, how do you find these people? There's an elaborate screening process. We do telephone screens in the clinic. They get PET amyloid imaging, MR, just to find this 1/3 of people who are really eligible. We originally had only 1,000 people in the study in the United States and Canada. We added Australia and Japan and went up to 1,150 people. So we had 67 sites across these countries. And we screened, boy, this is when I long for the days of those 20 people fMRI experiments. We screened over 6,700 individuals, and we did PET scans on 4,487 of those individuals. And the good news is that all of the screening data from A4 will be made publicly available. So all 4,487 PET scans will be available with all of their cognitive data and all of their other data as well. We hypothesized that our amyloid positivity rate would be 30% when we wrote the grant, and it ended up at 29.6%, so pretty right on prediction for that. We have, again, tau PET, as I already showed you, and we have a cohort in LEARN who is matched. The hard part is that we extended the trial out to 4.5 years and quadrupled the dose, so unfortunately it's really delayed gratification because we're not going to know the answers until mid-2022 from this trial. but I am going to show you some of the screening data because this is exciting to me. So these are preliminary. We're going to present this at AAIC. We're still doing a lot of data cleaning. We just finished our enrollment there in December. But looking across what's in the pack, the components I showed you from Beth's paper in the Harvard Aging Brain Study, this is the primary outcome in the A4 study, looking at decline over time. And what you can see is on every one of these components, the amyloid positive individuals perform less well than the amyloid negative individuals. We typically have not seen cross-sectional differences. Everyone looks the same. We can see longitudinal differences, but when you have this kind of sample size, even very small differences are quite significant. But I am really struck by the pattern here. Every single one of the tests, people perform less well. This is at screening visit 1, before they've had a PET scan, before they've had anything else. This is the first thing, and already you can see this difference. And importantly, I didn't talk much about subjective cognitive decline, but one of the other outcomes we have is a self-report and a study partner report about how do you think you're doing. All these people are still normal, but even still, the self-report and the study partner are slightly higher in the amyloid positive, similar to what's been shown in a lot of single center work. And then here's a little highlight. This is for Mike Yassa and Craig Stark. I don't know if he's around, but they kindly helped us put the pattern separation task. We put a face name task and the Cogstate card playing tasks. And this is very preliminary, but what I can say is that the test phase of the BPSO, as well as the 3-name forced choice and the 1-card learning are all significantly performed less well in amyloid positive individuals. And this really gives me hope. This is a computerized test on an iPad. This is given to 83-year-olds who've never used an iPhone, never played much, many of them, with these kinds of tests, and they're able to learn it and do it. And the next generation of clinical trials, we're going to be testing people like this on their iPhone, because the younger we go and the longer we follow people, we can't have them come in and fold a piece of paper every 6 months. Okay, so in my last few minutes here, I want to talk about the next phase. So one of the things we've been able to look at, I've got 5 minutes about? Good. Is accumulation over time. So here's some longitudinal amyloid accumulation. In red are the E4 carriers, in black are the non-carriers. What you can see is everybody above this level of 1.2, that's amyloid positive, this is PIB data, continues to go up. So that's one of the laws of amyloid. Once you've got some, you're going up, unfortunately. But these people who have very high amyloid at 65 and 70, they started to accumulate their amyloid back over here when they're 50 or 55. And at any age, you can see people moving from amyloid negative to amyloid positive. I've shown you previously that having very high amyloid, you've already got a lot of tau, and you're very likely to decline. So I think what we really need to do is prevent people from getting up to this level of amyloidosis to begin with. And that leads, this is data actually from recently that came out. This is Michelle Farrell, who's now a fellow at our group, but this is work when she was at Denise Parks, showing that these sub-threshold levels of amyloid are also predictive of cognitive decline. Susan Landau's paper came out last month showing people who went from amyloid negative to amyloid positive also showed evidence of memory decline. So even before you're positive, the accumulation of amyloid seems to be associated with this memory decline. And Stephanie Leal, I saw, is presenting on, at the lightning round on Sunday, and I think she's got some data in support of this idea as well. So that leads to the A3 study, where the first A stands for ANTE, as in before amyloidosis instead of ante, and we're trying to find people who we can predict with an algorithm are very likely to accumulate amyloid on the basis of having subthreshold levels, their genetics, their age, and their family history, and try to prevent them from moving up to this stage of amyloidosis that's associated with tau and cognitive decline. Now, this might sound crazy to you, but in fact, this is exactly what's happened in the cardiac world. We used to only treat people with cholesterols over 300, and now we treat people with normal LDL levels if they have other risk factors, such as diabetes or hypertension. It's also the case that the way we figured out cholesterol lowering was doing these secondary prevention trials, both in familial hypercholesterolemia and also in people who had angina, had an MI or a heart attack, but still had good heart function. So amyloid, I've been very amyloidocentric here. I don't think it has to be the cause of Alzheimer's disease. I'm certain it's only one critical factor, but if we get it at the right time, we can do what cardiology did, which is reduce morbidity and mortality due to cardiac disease by 28% just through lowering cholesterol. Ultimately, I think we're going to need combination therapies. And finally, I want to talk a couple of minutes about resilience, because I really think one of the factors we still don't understand is why some people seem more resilient to Alzheimer's pathology than others. This is some work by Trey Hedden looking at this. What is it? This is really looking at what is the difference between 65 and 85 in your cognitive performance. Most of that is actually shared among brain markers. So it's not having amyloid alone. It's often having hippocampal loss, white matter, and other changes. So it's likely a combination of multiple pathologies that really change the disease. And coming back to the fMRI roots, this is some work by Rachel Buckley, who's a fantastic postdoc in the group now, showing that even in the setting of amyloid, you can remain resilient if you have a good default network connectivity. So whatever you can do to keep that default network going, and I think sitting through this lecture instead of being in the sun maybe helps that. We'll see. All right. So I do want to say that there are many unanswered questions. I think we don't really know how people can walk around with a head full of amyloid if it's toxic for 10 years and some people not show much decline. Why are some neurons more vulnerable? Why does AD pathology target these very specific components in this memory network? Is the hyperactivity compensatory? No. But is it a sign of impending failure, and what are the mechanisms underlying that? And most importantly, from my point of view, what is the critical window that you can intervene and still save neurons? So I do want to acknowledge this is very controversial still. Everyone showed their favorite philosopher quote. This is mine of Schopenhauer's. I think that we might be somewhere between the ridiculed and violently opposed in preclinical Alzheimer's disease, but I'm hoping that with your help from the cognitive neuroscience world, the aging world, and the Alzheimer's world coming together, that eventually we'll get to the point where this is self-evident and we prevent Alzheimer's disease. I want to thank all the great people I work with in Boston, and thank you so very much for your attention.